Hello, everyone, and welcome to the Oregon Rural Health Conference presented by the Oregon Office of Rural Health. My name is Sarah Anderson, and I'm the Director of Field Services at the Oregon Office of Rural Health, and I will moderate today's session. First, I'd like to take a moment to thank our gold partners, All Care Health, and the Oregon Rural Health Association. Our silver partners, Eastern Oregon Coordinated Care Organization, and the Oregon Association of Hospitals and Health Systems, as well as the River House on the Deschutes. Our bronze partner, RQI, our copper partners, Westcom and the American College of Education, and INQUISEQ. Their continued support during these difficult times has made it possible for us to offer the conference at no cost to you. You should have received an email with a link to our conference app. Use this app to visit our partners' virtual booths and enter to win prizes. Network with others and share photos of your practice, providers, or community. We'd love to see them. Next slide, please. Before we get into the presentation, I will go over the technical aspects of the platform so you can have the best experience. Your audio is muted and your camera is off. Please ask questions through the Q&A box at the lower right-hand corner of your screen. I will ask those questions to our speakers at the end of the session. If you have technical questions, you can also ask them in the Q&A box as well, and we'll address those for you. For the best viewing experience, we suggest using the floating panel view. Please see the upper right-hand corner of your screen where you can select the different view options. The presentation and slides will be posted on our website shortly after the conference. Next slide, please. Please give us your feedback about this session by completing the survey following this presentation. To claim your CE credits, you must complete the survey. Complete the survey to be entered into a drawing to win a $100 gift card. We appreciate your feedback to help us improve the conference in the future. Next slide, please. So to present the session, Talk to Patients Living with Substance Use Disorders, we have Jim Winkle. Jim is a trainer and consultant and manages the SBIRT website. You can read more about Jim on our conference app or our webpage. And without further ado, I'd like to welcome Jim Winkle. Jim, the floor is yours.
All right, thank you, Sarah, and welcome everyone. Thanks for taking a little bit of time out of your busy schedule to watch this presentation, and I look forward to questions afterwards. I have nothing to disclose financially, and just to get a little sense of my background, for the last 12 years or so, I've been working a lot in the primary care world, trying to implement SBIRT, screening, brief intervention, referral to treatment. We had a couple of SAMHSA grants at OHSU Family Medicine. The PI was Dr. John Munch. We developed a 4-hour training curriculum. We helped 7 different clinics implement SBIRT. And then I started doing work as a consultant in different settings. So not just internal medicine or family medicine, but also pediatrics, women's health, and some emergency rooms too. We built a screening app, and I currently continue to consult. So why this presentation? There is a need in the medical world, especially primary care and emergency medicine, to better serve patients with substance use disorders. And that is because, first of all, it's not a rare condition, as we'll see. It's pretty prevalent, and they face greater risk of dying earlier than people who do not have SUDs. They face a greater risk of getting ill. And they do seek health care, but not because they want necessarily to talk about their substance use disorder. So someone with an alcohol use disorder may come in for an annual, or they come in for a sprained ankle or a sore throat or whatever it is. And hopefully if you screen your patients for substance use, you will identify most of these patients who do have a substance use disorder. The exception is people who inject drugs. For reasons we'll see, they don't, unfortunately, seek healthcare because mostly of stigma. But people with alcohol use disorders, you will show up in your office. So it's not rare, it's pretty common, and we can do a much better job as clinicians as far as our rapport with folks living with substance use disorders. And many providers, according to surveys in the literature, don't really feel prepared on how to do this effectively, especially when they don't have they don't have much time to do this. So these are the reasons for this presentation. So we're going to talk about stigma a little bit. We have about 40 minutes, so we're not going to go too deep into harm reduction, but just kind of review the principles. And then I'm actually going to leave you with a concrete 4-step model of how to have a conversation with someone living with a substance use disorder in a way that can engage them and even perhaps encourage them, if they're interested, increase their motivation to change their behavior, whether it's reducing their harm or abstaining. So when I said substance use disorders are not rare, the literature shows about 10% of adults at some point in their lives will experience one. There's a lot of death from alcohol-related causes. If you are a doctor and during your training you probably did rotations in hospitals and you probably saw a lot of end-of-life alcohol-related disease. A lot of injection drug use is going on. Of course, that's been on the rise in the last 10 years. A lot of opioid overdoses. So definitely not something that is rare. And this was a large study a couple of years ago done of 45,000 patients who were diagnosed with SUDs in Northern California healthcare system. It's probably the best study we have to date to give us a sense of what % of patients have which kind of substance use disorder. So as you can see there, alcohol is the most common, followed by cannabis, then opioid use disorders. And then, of course, unfortunately, people don't always just have one substance use disorder. So it shows if you have an alcohol use disorder, what % of these patients in this study had other disorders on top of that, cannabis and opioid. Also, as I said before, people living with substance use disorders face a greater risk of getting sick. There's 14, in this study, there's 14 different chronic health conditions that, as you can see by the graph, people with substance use disorders are more likely to be experiencing this comorbidity than someone without a substance use disorder. So a greater risk of morbidity here. And then mortality. People living with substance use disorders, especially opioid use disorders, as you can see, the green bars there, are more likely to die in 10 years than someone without a substance use disorder. So morbidity and mortality definitely are higher in this population. And then you may have heard researchers are increasingly using this term deaths of despair when they refer to suicide and deaths that are alcohol related and deaths from drug use. And those are on the rise in the last 10 years, especially as you can see from drug overdoses. So definitely a public health emergency in some respects that we should be dealing with. Specifically, if you're curious, of those opioid overdose deaths, this study sorted out heroin from prescribed opioid deaths from synthetic opioid deaths like fentanyl. And it's the synthetic opioids that have really increased, as you can see, since 2014. So definitely it's prevalent, a lot of illness going on and mortality. So what can we do if you are a healthcare provider? If these folks come and present to you, of course, like anyone else, they deserve general primary care, and that's important. But also when they come in with complaints related to their use, that's an important thing you can help your patient deal with. There's a long list of morbidity associated with risky alcohol use, in addition to having alcohol use disorder. And of course, if your patient's ready, you can help your patient reduce their harm. Maybe they are interested in injecting more safely or carrying Narcan on them if they inject drugs, or if they're heavy drinkers, there are ways to, if they're not ready to stop drinking altogether, there are ways to drink in a way that is less dangerous. PrEP is a medication. If someone's injecting drugs, PrEP can prevent them, and it's very good at preventing them from contracting HIV. That'd be a great thing to offer a patient who's injecting drugs. And if your patient's ready for medication to get off their substance, there are effective medications that you can prescribe as a provider. Some of them require an 8-hour training, like buprenorphine. but others do not. And then, of course, many people in recovery have pointed out a health professional in their past that they believe started them on the pathway to recovery. So what you can help your patient do is help them improve their life and reduce their harm, and that can begin, help the patient begin forging their own pathway to recovery. So these are some really important things that a primary care provider can do for their patients. Now, I want to talk about stigma a little bit. Why? This study is a good example of why, because it was a large survey of people with what we used to call substance dependence, using the DSM-4 definitions of that. And it asked them about a lot of different things, as you can see. Did they have a lifetime history of violence? Are they currently experiencing depression or other mental illnesses? Did they come from a life of poverty? What are their demographics, like age and sex? And I wanted to find out the study to see, of all these variables, which ones are the most highly correlated with the diagnosis of being dependent on a substance. And what they found was stigmatization. So the feeling of being stigmatized, if you perceive from other people, either professionally or culturally with your friends, that you feel stigmatized because of your substance use. These researchers found that was the #1 correlate predictor of being dependent on a substance. So this is a big deal, and it plays an important role in understanding people living with substance use disorders. So what it does is, when we feel stigma, it diminishes our self-confidence. It inflicts maybe even greater psychological harm than having the substance use disorder itself. We are social creatures. Our brains are designed to relate to other people. And if we feel ostracized and stigmatized, that can inflict psychological harm. And then, of course, if we feel stigmatized and it hurts our self-esteem, we are less likely to take proactive steps to reduce our harm from the use. And the irony, the cruel irony, is if we feel stigmatized from our substance use, taking the substance temporarily allows us to escape that negative feeling of stigmatization. And so that, of course, increases the stigma, and it's just a downward spiral. So with patients specifically, these studies show that when patients feel stigma, they're less likely to overcome barriers to getting to see a doctor, whether it's transportation or getting insured or having stable housing, or really putting up with the stigma they feel from healthcare providers, which we'll talk about. They're more likely to not disclose to you their substance use because they're afraid of being further stigmatized. They're less likely to report a positive conversation or rapport with their provider. If they go to treatment, they're more likely to not go or interrupt it, not come back and see you. So obviously this impacts patient care. And unfortunately, it's not just the patients themselves living with this. They have good reason to feel stigmatized, because surveys show that providers do feel stigma towards this population, unfortunately. And it's not rare, it's pretty common. Medical clinicians do report having a bias against people living with substance use disorders. They tend to believe they're less honest than a patient who does not use a substance, that they're less vested in their own health, or they'll abuse the system. So there is the stigma coming from providers. There's been some focus groups, people who inject drugs in this case, and I wanted to share just a couple quotes because I think they're pretty revealing. So these are anonymous names, of course. So Donna says, the minute they find out you inject drugs, you can see it right in their face. They change their whole attitude. They don't want to help you. I hate telling the doctor that I use drugs. Their whole attitude changes. So patients obviously are sensitive to the reaction they perceive when they disclose drug use, and that is a barrier to disclosing it. Stacy says, when it comes down to it, a lot of the times that I need to get medical attention, I put it off and put it off and put it off because I don't want to face the embarrassment that they make me feel. And that's not fair. Mary says, I don't want to tell them I'm a drug user if there's something really wrong with me. I need that issue taken care of. It makes me want to lie and not be honest. So people coming in with a health complaint, like an injury or something else that may not be related to their drug use, often are afraid they won't get that complaint treated if they do disclose their drug use, because suddenly the doctor will focus just on the addiction and try to fix that and prioritize that over everything else. And they don't necessarily like that, patients. Richard says, she wouldn't help me keep my appointments. She would care less. She wouldn't go the whole 9 yards or go out of the way for me. So people do expect less quality care when they disclose injection drug use. And Aaron says, there are just some things I wouldn't tell a doctor. So obviously, this is a problem if you're a doctor or a PA or a nurse practitioner trying to give good care to a patient and they're not disclosing to you something that is obviously impacting their health. This is a barrier to you providing excellent care to your patient. And a theme in the literature, these focus groups of people who inject drugs, is a lot of times they'll say that they perceive the stigma non-verbally. So a lot of quotes about being looked at in a certain way. And it's not just the doctor, it's often reception at the front desk or maybe the rooming staff. They feel like they're looked at like garbage, or they just get dirty, snotty looks. So this is one way stigma is conveyed, not just verbally. And unfortunately, studies do show that when providers have stigma, it does lead to worse care. So in this study showed, or these couple studies showed, that providers who disclosed the stigma to the researchers, after follow-up, they show that they're less likely to help reduce the harm of the patients, less likely to offer therapy to HIV-positive patients, less personable, less likely to engage with these patients, and they don't really address the substance use in a helpful way. So there is a correlation here that stigma is tied to worse care. So we've made the case that stigma plays a large role in the health care of patients living with substance use disorders. So it's worth looking at, where does it come from? And researchers pretty much know where it comes from. They identify two main causes. So if someone, whether it's a doctor or anyone really, if we perceive that an individual is responsible for causing their behavior that we stigmatized, or that we believe they should be able to control their behavior that we stigmatize, that's where stigma comes from as a judgment. So if we believe someone caused their problem and they should be able to control it, we're more likely to have stigma towards them. And of course, the language we use really helps either mitigate stigma or further it. So let's look briefly at that. You know, when it comes to addiction to substances, you probably know as a medical professional, hopefully, that the brain science has come a long way. And we really understand now that when someone is addicted to a substance, it really impairs their efforts to control their use. It's not the same as a brain who is not addicted to a substance. When they're given the choice or the opportunity to use a substance, even if they find it pleasurable, if they're not addicted to it, it's a very different scenario than when someone is addicted to a substance. And the difference is our efforts to control our own behavior. And then another way to look at it too is, you know, if you're in public health, I'm sure you've seen, you know, the problem tree, where in the middle is the problem we're trying to address, which is substance use disorder. And on the top, you know, these are the negative outcomes from it that we want to decrease. But what are the roots? You know, what are the causes? And we know there's a lot of research out there that shows all these correlations. You know, we're more likely to be living with a substance use disorder if we have experienced abuse in our past, and if we have high stressful lives, if we've been exposed at a younger age to a substance compared to an older age. We have low self-esteem. We have a comorbidity like depression or anxiety or schizophrenia. We have a family history of addiction, trauma, poverty. So there's a lot of things that really set us off at behind the starting line, as it were, way back compared to someone who doesn't have these things in their lives and their chances of experiencing addiction. So this is just more things to remind yourself of when you're feeling biased towards this population, is that someone's background can really make them more likely to have a substance use disorder than someone who does not experience these things. So it's again, the cause, are we really responsible for our own addiction? So an interesting question. And don't forget the role of our own industry. I'm sure we know by now that the drug industry spent a lot of money marketing to medical professionals to try to get them to prescribe painkillers. They targeted parts of the country that they knew were low income and more likely to be addicted to opioid products. So when it comes to someone causing their own addiction, let's keep in mind that our own healthcare industry, unfortunately, played a very large role in creating this epidemic of opioid addiction. And, you know, the science is pretty established. By the time a Surgeon General's report comes out, it's been settled. And so, again, it confirms that brain imaging shows that there's really physical, concrete changes to a brain when someone is addicted to a substance. And it relates to how they can control their own behavior. So if you believe someone is, again, is responsible for causing their addiction, or if you believe they can control it, those are two things that are more likely to make you feel stigmatized towards this population. The other way to convey this or mitigate it is by the language you use. So I just want to pull up some examples of what language we should be using. For example, injection drug users is probably outdated phrase by now. We should use person-first language. So less stigmatizing language would be people who inject drugs, someone who injects drugs. So the first word we use is people, because these are people who are beyond just their drug use. The drug use does not need to define an individual. And even the words abuse and dependence have negative connotations, or the word habit, and those are old DSM-4 terms. So now we use substance use disorder, which you probably already know. We should describe, again, someone living with or someone who has a substance use disorder, as opposed to, we don't really even use the word alcoholic anymore. Clean and sober, you know, that implies someone is dirty if they are using a substance. So maybe it's better just to say person in recovery. Dirty or clean needles, how about used or new needles? Positive or negative result on a drug screen is a more accurate way to describe it rather than the subjective terms dirty and clean. And then the medication-assisted treatment, people are starting to move away from that because medications out there like Suboxone are effective alone. They don't have to accompany a different kind of treatment like cognitive behavioral therapy in order to be effective. They are effective alone. So we just try to say medication for opioid use disorder or medication for alcohol use disorder or whatever it is. And if we describe a population as high risk, maybe we could say individuals at risk of acquiring a morbidity. So words really make a difference. And if we use phrases like this with our coworkers, not just only in front of patients, but with people we work with, we can help convey a more non-stigmatized atmosphere rather than one that furthers stigma. So I'm going to jump to the last 10 minutes. I think it's most important to get to what can we actually do when we talk with a patient. So a lot of times this is called a brief intervention. You can call it something else if you want, but when you learn something new, it often helps to have a model. So I'm going to teach this 4-step model, which you can call a brief intervention. It's a model to use whenever you want to talk to a patient in a way that helps them increase their own motivation to change. So let's get into this model. The first step is, now this can be in a primary care setting. It could be an emergency room if someone comes in with an abscess or an injury because they were drunk and you're talking to them when they're sober, or wherever it is. After you've addressed the complaint that they've come in with, and you want to then explore a conversation with them about their substance use, a good way to raise the subject is simply by asking permission, which may seem like a formality, but it actually sends an important message. When we ask permission, something like, now that we're done going over your diabetes medications, I see that you filled out one of our alcohol questionnaires. Thanks for doing that. Is it okay if we go over it together? Is it okay if I have a look? When you ask permission, you're sending a message to your patient that you want to embark on this conversation together. And that's different than your patient maybe expecting that they're going to get a lecture. So always ask permission. And then it's good to be a little bit transparent about your role. And I have an example of here what that might look like, because your patient doesn't really know what to expect if you want to talk about substance use with them. So it's good to just use a few sentences like this. Just so you know, I'm not going to tell you or advise you to stop or change your substance use in any way that you don't want to. Instead, my goal is to help you understand what your goals are, your vision for the future. Now, I can share information with you, as a medical professional, so you can decide how to improve your quality of life on your own terms and on your own timeline. So how does that sound to you? So something like this really sets the foundation for a productive conversation, because now you've explained to your patient what your role is in this conversation. So going back, to raise a subject. So ask permission, state transparency about your role, and then ask the patient to describe their use. In your own words, I'm curious, can you tell me about injecting heroin? How often do you do it? Where do you do it? Where do you buy the substance? I'm curious to learn a little more about your behavior. The next step is sharing information. So your patient deserves to know if they came in with, insomnia or stomach pain, or they have depression or high blood pressure, and they have an alcohol use disorder. They deserve to know that there is a correlation. I can tell you as a doctor that we know people are more likely not to sleep well, more likely to have depression when they drink too much. What are the risks of substance use? This is also good information to share. I can tell you a number of things are more likely to go wrong when someone is addicted to a substance. They can create new health problems. They can make existing ones worse. And you can share information with your patient about what those risks are. And it's also okay to be honest about your concern. I care about my patients. I want them to be as healthy as possible. So I'm concerned about your injection drug use. I'm concerned about your alcohol use disorder because I know it can lead to a lot of health problems. So after you've shared information, ask the patient what they think. I've just given you some information. I'm curious, what do you think about what you just heard? Do you have any questions? Now, in the old model, I think, especially in the SBIRT world, this second step would have included, like, I formally recommend that you abstain from using alcohol or quit injecting drugs. But under a harm reduction framework and under an evidence-based framework, because we know it doesn't really lead to any change, it's good just to leave that aside. It's not important to give a formal recommendation to your patient. Why? Because if you tell your patient that they should do something, it implies judgment, and they already probably feel stigmatized about their addiction, and they probably aren't going to quit as a result of seeing you one time in the exam room. So knowing that they're not meeting your recommendation risks furthering the stigma that they probably already feel. The other reason is it comes from you rather than your patient. So that's shown not to help. That may reflect your own need to feel like an effective clinician by convincing your patient that your recommendation should be followed. So that's not what we're striving for here. And like I mentioned earlier, people with SUDs already feel trapped often. What they need is options, new options that they haven't thought of before. You want to broaden the world of your patient when they're addicted. You don't want to further limit it by giving them an ultimatum, whereas you either keep using and face the consequences, or you need to abstain altogether. That's just not true. There's a lot of things patients can do to reduce their harm when they're not ready to abstain. So, third step, you've shared information, you asked them what they thought about it, and you should, when you ask a patient about their use, you should ask them too, I'm curious, what do you like about your use? And I'm also curious, what do you not like about it, or what concerns you about your use? People start to change their behavior when they begin to perceive the consequences are outweighing the pros. So to get them to start making that judgment, it's good to ask them about both. You're also kind of sending the message that you are a fellow human being who understands and empathizes why someone would take a substance and become addicted to a substance, because there are positive reasons why people use alcohol and drugs. So ask your patient what they like about their use and what they don't like. And then you should reflect that. On one hand, I hear you say that, drinking several drinks after work makes you feel relaxed. It's a fun way to spend time with your friends. To you, it doesn't seem like you have a problem with alcohol. On the other hand, I hear you told me you got a DUI, and that really was hard for you to keep your job after having a DUI. Your wife or your husband nags you about your alcohol use. So I'm curious, weighing those two things, where do you want to go from here? Here's some examples of how to phrase that question. Over the next few weeks or months, what would you like to see happen for yourself? What would you like to do about your substance use? Is there anything you'd like to change? Where would you like to go from here regarding your use? Kind of open-ended questions about, okay, you've told me what you like, what you don't like, and now I'm curious, what would you like to change? This is important because when people verbalize their own goals to change, they're more likely to achieve them, or at least increase their motivation to achieve them. So whatever the goal is, try to get your patient to define it in a concrete way as possible. Hopefully it's a goal that is a positive one. It reduces their harm or improves their quality of life. A time frame is nice because that makes it more concrete. In the next 4 weeks, I'm going to use only clean needles, or I'm going to shoot more safely so I don't cause an abscess, or I'm going to work on getting help to get stable housing. So whatever it is, time frame is nice, and make sure it comes from them. If your patient is totally at a loss for any ideas about how to change their use, you can ask permission if you have some ideas. Something like, other patients of mine who struggle with addiction they're ready to do, this or that. Is it, I have some ideas. Is it okay if I share them with you? So with permission, you can share the ideas. So what are some examples? People who inject drugs, again, they are likely not going to stop injecting drugs right away, but they might be interested in injecting more safely or not share as much. Maybe they'll carry Narcan so they can overcome a overdose if they see a friend overdosing or a friend can use it on them. Maybe they are willing to use less frequently. Maybe they're willing to accept treatment. Or they can just take better care of their abscesses, or maybe nothing, but they are willing to come see you on a regular basis just to check in about their health condition, which would be great because people who inject drugs typically do not see a healthcare provider. Or someone who drinks too much, maybe they're not ready to stop drinking, but they're ready to drink in different places. Maybe they're ready to make sure they eat a full meal before drinking. Maybe they're willing to drink something with less alcohol content for a while. There's a number of ways people with alcohol use disorders may be willing to try to reduce their harm even though they're not ready to stop drinking. Whatever the goal is, you should try to gauge how confident they are to reach that goal. And you may have heard of this before, but when you don't have a lot of time, using the Readiness Ruler is a nice way to do it. So I'm curious, on a scale of 0 to 10, with 0 being you're not ready at all to make sure you access clean needles in the next 4 weeks, and 10 being you're really ready to do that, where would you put yourself? And when someone gives you a number, it allows you to follow up with this great question, which is, you told me that you're a 5 on the scale. I'm curious, why not a lower number? You could have gone with just a 2 or a 3. Why do you think you picked a 5? And when a patient answers that question honestly, they'll say something like, well, I guess I'm a 5 instead of a 3 because, I had a friend overdose last week and I don't want that to happen to me. Or I really want to make sure I don't have another infection in my arm. Whatever it is, you've got your patient to, again, verbalize motivation to change their behavior. And that act of verbalizing it is what's shown to increase motivation. So that's kind of the purpose of this readiness ruler, is to get your patient to verbalize motivation to change their behavior. Now, if they're above a 5 on that scale, or just in your own judgment, they just seem ready to take a step, a plan of some sort to achieve their goal, it's simply a matter of asking them, sounds like you're ready to try to achieve this goal. What kind of plan would you come up with to make sure you do that? So again, letting the plan come from your patient rather than you. And the plan could be a number of things, but whatever it is, it comes from the patient. When they're done with that, you should affirm their readiness to change. I'm great. It's great to hear that you have a plan and that you're motivated to do this. Would you mind coming back in 4 weeks, 6 weeks, whenever it is? Because I'd be curious to hear how it goes. I'd be curious to hear what was hard about the plan or what you were able to achieve with it. And maybe you're ready to revise the plan or even come up with an additional plan at the end. So if you can get your patient to come back in to talk about it, that's a big win. Because as we heard, this population typically does not seek healthcare. So this is a review of the 4 steps that I just went over. On the SBIRT Oregon website, you can find this, and you can find pocket cards and other resources you can put in your exam room. And the kind of the take-home message here is defer to the patient's wisdom. So even if you feel like you did not achieve anything worthwhile in your short visit with someone living with a substance use disorder, simply by using language that does not convey stigma, by treating your patient as a real human being, by recognizing even someone who's addicted to a substance, by recognizing their autonomy, the more the autonomy they feel and the respect you feel for them, the more likely they will step up and forge their own pathway to recovery or their own pathway to achieving a goal. So I will recognize our time here and scoot to the last slide. That was a very quick 40 minutes on how to engage someone, talk to someone in a productive way who is living with a substance use disorder. And now I turn it over to Sarah.
Thanks so much, Jim, for the great presentation. We're going to go now to the question and answer session. So please remember to ask your questions in the Q&A box on the right-hand side of your screen. Thanks again, Jim, for a really great presentation, and welcome everyone to the Q&A portion of our presentation today. As a reminder, you can use the Q&A box at the bottom right of your screen to add questions for Jim, and we will make sure that we get to those. And we are going to start with our first question, which is coming in from the app, Jim. So how do you help caregivers who have moral and ethical dilemmas when meeting patients where they're at?
Right, great question. Because that will happen sometime. For some providers who are exposed to harm reduction for the first time or behavioral health specialists, it may be not such an easy change. For some people, it's a real paradigm shift to go from an abstinence-first approach or abstinence-only approach to trying to improve someone's quality of life instead, or focus on reducing their harm. So if you have providers like that, first I would validate their dilemma, because it could contradict their training to some extent. So acknowledge that. And then look into a training, whether it's from me or a harm reduction coalition, because the way people can change their perspective and shift their paradigm towards a more empowering attitude towards a patient is to look at where their bias or stigma comes from. And that means examining our preconceived notions about maybe people are somewhat responsible for their addiction, or they're responsible for controlling their behavior. And we know that's not true because of how their brain changes. So validate their concerns and their dilemma, but look into training to help them make that shift and do a harm reduction approach.
Great, thank you. Another question from our app: how do you help employees find more kindness and compassion for addicts who are struggling?
Right. Uh, if this were a longer training, I would have had a couple slides in there of focus group quotes from clinicians or nurses and receptionists who struggle sometimes with what we call difficult patients. And even people who are addicted acknowledge themselves sometimes that they're not always in the best mood when they show up for an appointment after being rejected from other clinics because they don't have insurance or they've traveled a long way. So how do we change that? Again, training. Take an hour or two outside of your patient schedule to get these folks in a training with a skilled facilitator so we can explore where that bias comes from and look at the perspective of maybe people living with substance use disorders. Where are they coming from? What, like those focus group quotes I put in there earlier, the experience they feel when they go into a clinic or an emergency room and they feel looked down upon. They know if they disclose their use, their treatment or their care will change dramatically. Try to understand the perspective of the patient is the way to reduce our bias and recognize the humanity of these patients. Because, in context, if we have a patient with diabetes, for example, that's hard to control, we patients probably know that their lives are much more than their diabetes, even though they're eating poorly, they're not exercising. But we know that they have interests, they have friends, they have parts of their lives that are not about their diabetes. It's the same with addiction. Even someone who, is struggling with homelessness and addiction, they have parts of their lives that don't involve substance use. It could be their friend network, it could be their favorite things, their sports team, what they like to do. So these are all ways to kind of increase, I guess, our perspective of humanity towards these patients, and that usually is done through training.
Great, thank you. Similarly, how do we reinforce the humanity and dignity of our patients who need more help, whether due to addiction or houselessness or any other reason?
Right. I'm not an expert on homelessness, but obviously that's correlated with drug addiction. How do we reinforce the humanity and dignity? We need to step out, again, like I mentioned before, of our provider or clinician role and take a break from that and look at some different perspectives. And that, again, requires having someone come in and talk with your staff about this. Or if they want, there are online workshops you can engage in too. But when we want to readjust our perspectives or take a new look, adopt a harm reduction approach, it's going to take a time to step out of our clinician role and talk about these things with a skilled facilitator. And by the way, I'll add that we do have some evidence on why some providers are more apt to have good rapport with people who are addicted compared to other providers. And those factors are if they have training in addiction medicine, or they have experience in their training working with patients who have addiction, or in the third factor is if they've gone to a harm reduction training. So those are the three things we know that are correlated with improving care between providers and patients.
Great, thank you. Another question here from the app. How do you deal with simply non-compliant patients?
Right. Well, the first thing I would say is you might look at that word non-compliant. It might be a little judgmental because we are issuing orders and the patient is not complying. Maybe look at it as why, get to know your patient a little more. Why are they maybe not adhering to a treatment plan or taking their meds every day as recommended? Try to be pragmatic. Not everybody, for example, brushes their teeth every day or has their coffee every day or exercises every 2 days or whatever the recommendation is. We all probably don't do the thing we're supposed to do to keep us healthy. So if you have time, which not everyone does, but if you have time to sit down with a patient and find out what does work for them, what would help them take their medication every day, for example. You may be able to figure out some strategies to elicit from them what a plan would be to help make that happen. that's more likely to work than just issuing a treatment plan. You need to do this, give them the piece of paper, and then be frustrated when they don't live up to your expectations.
Another question, which has just come in through our Q&A from Dana Jackson. What are your favorite resources for finding trainings, like you mentioned, addiction medicine, harm reduction, etc., if our clinic, if our clinic does not offer them?
Well, I am a harm reduction trainer, and I do trainings once in a while for clinics on this. Since COVID online, 2 hours is great, if possible, but I'll take what I can get if it's just an hour. It's hard, obviously, to pull providers out of their patient schedules to do a training, but I'm a resource. But then there's also the Harm Reduction Coalition. There's an office on the East Coast and the West Coast, and they also offer online training. So really, the Harm Reduction Coalition is a great resource.
Great, thank you. Okay, another question from the app. Suicide rates are on the increase. How can you help people on drugs to quit and stay out of drugs?
Right, so this question was probably written before the presentation. We don't want to focus or try to fix our patients by getting them to just quit for the reasons that I stated, in the training. Because if we do that, we imply judgment. We're just going to frustrate our patients, frustrate ourselves, and really it's about your own need as a clinician to hear something from the patient if you're trying to get them to quit. How we get them to quit over the long term is by helping them come up with a plan to improve their quality of life and reduce their harm. If we can help them do that, that's how they can begin to forge their own pathway over the long term towards recovery. People in recovery have told me often, like I mentioned in the training, that it wasn't that they went to a doctor and the next day they decided to quit, but it was some kind of health professional who helped them use clean needles or help them inject more safely or help them drink more responsibly, where their lives improved. And once they became more stable and reduced their harm, eventually they chose to accept, Suboxone, or they chose treatment for their alcohol use disorder. So the road to recovery is usually a long-term one, and it's a windy road. It's not a linear problem that we can solve in a visit. So try to lose the focus on convincing your patient to quit or convincing them to do anything, and try to elicit from them instead what they want to do themselves and help them do that.
Great. Alyssa Phelps asks if you have used this model with veteran populations as well.
Yep. There's really no population that does not benefit from a harm reduction approach. Addiction is a common denominator across populations. So veterans, of course, would fall under that category of being in a group that would benefit from an approach that focuses on them as human beings and not trying to get them to quit right away.
Thank you. Another question, which is up in the chat, advice for providers under pressure to meet performance goals who see their role as addressing issues associated with their specialty and fear taking on substance use issues.
Right. People I think are afraid to get certified to prescribe Suboxone in a lot of ways because they're afraid to take on these patients, right? And we're all trying to meet performance measures. I would try to remember that, as far as I know, there's no performance measure that holds providers accountable for the behavior and the decisions their patients make around substance use, at least not ones I know of. What you should be accountable for as a provider is to perform this brief intervention that I talked about with as much fidelity as you can, to do a high quality harm reduction informed brief intervention with the patient. That's what you should be accountable for. And maybe for screening everyone. We should screen all our patients once a year for this, and then do a great brief intervention. And that's your responsibility. And then you're done. You don't stick around trying to convince your patient to do something or say something. You're done, because not only do you need to move on to the next patient, because this is primary care usually, and you're not a psychologist who has an hour, to work with this patient, but also because that's how behavior change works. People use the analogy of watering the seed of change that is intrinsic in all of us. And that's what this model does, is kind of water the seed of change. And when you perform it and then you let it go and let the patient go and sit with it, that's what leads to progressing to the next stage of change. Someone who's pre-contemplative may come out of your visit being contemplative, because now they are starting to think about the pros and cons of their use. So if you're taking on these patients, try to remember that you are absolved from trying to convince your patient to do anything. You're not your patients have autonomy, and you're not responsible for their behavior.
Great, thank you. And we are just about out of time here, so I am going to ask you one last question here. And for any of you who haven't had their question answered here, we'll make sure that we get the questions to Jim and post the answers of these questions on our website afterwards. So the last question is, how do you deal with patients failing to accept a final answer? So they keep calling and asking to speak with other staff members in hopes of a different answer.
Yeah, and I'm not sure what different answer you're referring to. Maybe they're trying to get a prescription for their back pain. That's an often complaint of folks in healthcare, is what do we do with a person who keeps calling different providers, provider shopping, in order to get prescribed a painkiller. That is, and that kind of falls under the category of how we deal with difficult patients, quote unquote, when they call us. There are resources for that, but specific, when we're seeing a patient in person during a visit, again, try to elicit from them why they're looking for something. I'm curious to hear. I know that you contacted this person and you got to know, and then you contacted this person and got to know. I'm just curious, what are you looking for, and why do you need this? If you heard from a provider that they're not willing to prescribe you this medication for your pain, why do you think that is? Why are you convinced? Try to see it from your patient's perspective, and then share with them your perspective. This is why I can't give you a yes answer today. This is why, based, in my practical guidelines as a clinician, why I'm not going to prescribe this. So try to separate your patient's worldview and their concerns and what they want from yours. You don't have to mash the two together. You don't have to convince your patient that it's really your worldview that they should adopt, or your explanation. It's okay to keep the two separate. You validate what your patient is saying, you reflect back their reasons and what they want, and then you also give your reasons and your perspective. The two are separate. So keep a separateness, is what I'd say, between the two perspectives.
Great, thank you, Jim, and thank you so much for such an important presentation. We really appreciate it and appreciate you being here. So as I mentioned, we're going to make sure that any unanswered questions that you have, either here in the Q&A or in the app, are posted online shortly after the session. And we are going to take a short break right now and return at 2 o'clock to hear Equity and Inclusion in Rural Healthcare with Amy Heikkinen from Stratus Health and Candy Picker from St. Charles Healthcare. So thanks again. Thank you, Jim, and thanks to everyone who attended this session.